Thank you so much for joining this webinar. This webinar has been put together by the Makerere University Lung Institute to commemorate this year's World Asthma Day. World Asthma Day was designated the global initiative, global initiative for asthma, together with the World Health Organization. The flagship event, flagship day for raising awareness about asthma. Asthma, together with other lung conditions, including tuberculosis, COPD, lung cancer, are some of the biggest killers worldwide. And these are problems that are also coming into our setting down here in Uganda. So I am happy to inform you that our panelists, we have, what we have arranged for this afternoon is a panel of speakers and a conversation around the topic of asthma. And in-house, we have the panelists already with us. And I want to right away introduce them and then get started. Okay, first I'll start with the Dr. Katagira, who is based at the Institute as a physician and researcher. He is also the head of Department of Research and Innovation, and he has been involved in a number of co-investigations on airway disease and pulmonary rehabilitation. He's also currently pursuing a PhD training at the University of, difficult one to mention, in UK. How do they pronounce this, Wincy?
Leicester.
Leicester University, so the C is quiet. Yes. So Wincy, you're welcome, and thank you for accepting to be with us this afternoon on this rainy day.
Thank you.
I'm also happy to inform you, colleagues online and in-house, that we have Professor Lynn Atuyambe. Prof, I'm your former student. Yes, and I'm happy that I am where I am because of some of the knowledge you passed on to me. Prof is a public health scientist. As I mentioned, four universities across Africa and in the US to address the problem of air pollution. And this he has been doing for the last 20 years. And so, Prof, we are happy to have you in-house, and we really are looking forward to tap into some of your insights on this topic. We also have Dr. Jessica Nsungwa, Commissioner, Ministry of Health, with PhD training in health system development, which is a wonderful achievement. She is a pediatrician by training and currently serving as Commissioner, Ministry of Health, in charge of reproductive health at the ministry. And she's had over 20 years of accumulated experience in policy, programming, and monitoring, especially in issues around community health systems. And therefore, we are very happy to have you, Commissioner. And we also look forward to your remarks and comments around issues of asthma and air pollution. Finally, we shall have lived experience from somebody who has asthma, and this is none other than Violet Alinda. Violet, you're online. Can you say hello?
Hi, everyone.
Hi, Viola. Thank you for joining us. So Viola will share with us her lived experience of having asthma. She's currently the country lead for Twaweza,
East Africa.
Yes. And she oversees research from a qualitative aspect and also manages resources for the Rotary Club at Nsungwa. So once again, thank you for joining this webinar. And as I promised, we shall start right away in the interest of time. by having some remarks and presentation. First by Dr. Katagira. Over to you, Wincy. Colleagues, panelists, you have 10 minutes so that we have about 30 minutes for 40 minutes for Q&A and other conversations. This one.
Okay, just trying to put the slides in presentation mode. Okay, very nice. Thank you so much, Chair, for introducing me with very kind words. I know it's a packed program, so I have only 10 minutes during which we will just share just a few basics about asthma and probably why it would interact quite a lot with the air that we breathe in. So yes, so this is going to be the brief outline. I hope with the time that we have, I'll be able to delve into as much as I can. So maybe just straight away as a way of definition, I will share what the GINA definition for asthma is. And GINA defines asthma as a heterogeneous disease, usually characterized by chronic airway inflammation. And it is usually characterized by a history of respiratory symptoms. Chief among them is wheezing, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. Now, this is a short definition. When you look at the definition from the American guidelines, it's a bit more detailed. I think my screen is a bit frozen. Sorry, just trying to, sort out my slides, which are a bit frozen. Yes, when you look at the American definition, it's quite detailed, but I like it because it really summarizes everything about asthma in just one definition. So what we see here again, you see that it's a chronic disorder involving the airways in which many cells and cellular elements play a role. Now you see here that the hallmark of this disease, of this condition, is actually chronic inflammation associated with airway hyperresponsiveness that leads to, again, you see the symptoms coming back: wheezing, shortness of breath, chest tightness, and coughing, particularly at night and early in the morning. And these episodes usually are associated with a variable airflow obstruction that is often reversible, either with drugs or spontaneously. And I think here again, like I said, it summarizes the entire story of asthma, because for some people, actually, the symptoms just abate. They just disappear for some time without really needing to use any medicines, only for the symptoms sometimes to come back even a decade later. But one of the things, again, that you see here, when you combine the two definitions, there are certain highlights that come out. Number one, chronic disorder. Number two, involving the airways. Number three, chronic inflammation is a hallmark here. And then, of course, our symptoms: wheezing, shortness of breath, chest tightness, and cough. Now, one thing that you will see very clearly is that you don't need to have all the four to make a diagnosis of asthma. I will probably see that in the coming slides. Now, when you look at the burden of asthma, the studies that we've done so far show that the prevalence of asthma stands at around 11%, 11.02% in Uganda. The highest in Africa that we have is in South Africa, and it's about 20%. You can actually see that we are not so far behind, and some people actually argue that probably the observed prevalence is probably slightly more than what some of the studies have seen, because when you look at how the studies are conducted, the inclusion criteria is quite strict. So that's actually why some people actually experientially think that we have quite more asthma than actually what we've found in the studies. But you can actually see that again, the disease characteristics are chiefly three. Chronic inflammation, which I've mentioned, airway hyperresponsiveness, which in plain English, I will say that the airways or the pipes inside the lungs overreact to the normal stimulus. So that's what we call airway hyperresponsiveness. And this airflow limitation, which really makes the pipes to become a bit narrow and will give us the symptoms, which mainly are the difficulty in breathing and the chest tightness and the chest heaviness. Yes. So when you look at the risk factors, you will actually see that most of them are really environmental factors. We have some of the host factors, and these you can actually see. We see obesity, gender, genes, strong emotions, and this you can see laughter, anger, grief, crying, anxiety, depression, emotional shock. So all these actually can actually trigger an asthma attack. And just to briefly probably summarize it here, the strong emotions eventually will recruit what we call the autonomic nervous system in our bodies. And it is chief among them, the vagus nerve, that will cause the smooth muscles inside the lungs to actually constrict. And once they constrict, they will bring on the symptoms. And again, you probably will explain, you all probably be able to understand why people, some people actually can collapse when they're extremely angry or when they are going through a very emotional situation. Sometimes it is shock, sometimes it is depression, sometimes it's really bad news. And someone all of a sudden will develop the difficulty in breathing and just blackout. So this is really because of the vagal stimulation inside the lungs. So when you look at the environmental factors, you will really see that they are quite extensive. All kinds of smoke, tobacco, biomass burning, and rubbish burning. Fumes, these will include strong perfumes, air fresheners, spices, in the kitchen, hand sanitizers, tear gas. Exhaust fumes, and these are really just all fumes that come from an engine. So it could be a car, a generator, factories, motorcycles, heavy machinery. For example, these machines that we use to slash up compounds at home. Then when it comes to weather, you can see all manner of weather, cold weather, rainy weather, changing weather. There are some people actually who will tell you that I will know in the morning if it is going to rain in the afternoon or the evening. And this is really just because of that changing weather. Causing the reaction inside our airways. So hot weather for some people, evenings, night, mornings, wind and fans, anything that really will replicate wind that is moving very fast. Then coldness, and you hear patients talk about all manner of coldness, SCs, drinking or eating cold things. Sometimes it's really any contact with a cold surface, touching cold surfaces, or even stepping on the cold floor will actually, cause or bring about the symptoms, especially the chest tightness. Then pollen, this can be from flowers, trees, or even the herbs that we like to take in our teas. Then dusts, all forms of dust on the roads, clothes, even occupational dust from our workplaces. And then outdoor allergens, animal dander, cats, dogs, goats, and other animals, as well as other moving things like cockroaches, dust mite, fungi, and mold. You can actually see that the environment causes quite a significant amount of trouble for people with asthma. And when you go back to really understand, you will realize that a single human being, for example, in a day, will breathe in about 11,000 liters of air on a daily basis. Now, if you want to know the size of the 11,000 liters, just look out and find the biggest water tank. Those big water tanks usually are 10,000 liters. So you really need, as a human being, you need on average that single huge tank on a daily basis. So it basically means that your lungs are constantly interacting with all these elements on a daily basis. And sometimes just one breath, which is really about 2.3, 2.5 liters, about one breath of bad air will already start causing symptoms. And sometimes a single individual will interact with a number of these triggers at the same time. And that really will bring about the symptom that was the asthma symptoms. Yes, so when it comes to the evaluation, clinical evaluation, I again mentioned that you don't have to have all the 4 symptoms of asthma for us to make a diagnosis. Overall, if you have 2 or more of these symptoms, so sometimes actually, depending on the phenotype of the asthma the patient will have, sometimes they'll just have chest tightness and shortness of breath, and that is it. And when you actually go ahead and investigate, you'll actually find that actually the patient has asthma. So sometimes, of course, people will really insist on the presence of a wheeze, but in doing so, you actually tend to miss a number of patients. Then you also will see the supporting history, which will come about in the recurrence of symptoms, the presence of other allergies, personal or family history of asthma or allergies. And then sometimes people will tell you that when they take certain syrups, they'll actually improve, they'll experience an improvement in the symptoms. And when you actually examine these syrups that people actually are talking about contain salbutamol, which is a known bronchodilator. So sometimes that improvement on a bronchodilator therapy can actually give you some bit of an idea that actually what you might be dealing with is asthma. Then again, we've talked about extensively all these triggers, so I will probably not waste a lot of time in listing all of them. But to really note for most of the clinicians here is that quite often the examination, the physical exam actually will be normal. And you will hear other people telling you, but doctor, the patient did not have an asthmatic chest. Well, there is really no term as an asthmatic chest. I know that people would really want to either listen to a rhonchi or a wheezing to, on physical exam to actually confirm a diagnosis. But most of the patients will have a normal physical exam, even an auscultation. All right, so again, after going through the history, physical exam and investigations, you will have to make sure that what you actually are dealing with is asthma. So we do a number of investigations, both to confirm the presence of asthma, but also to rule out other possible diseases that can actually present as asthma. So we'll quite commonly request for chest X-ray, spirometry, to really try to appreciate what is happening inside the lungs. But also quite a number of cardiac illnesses will present with a cough, difficulty in breathing and wheezing, for example, heart failure. So for some patients, we might require to do an ECG and echo. And once we have confirmed the diagnosis of asthma, we'll go ahead and grade the severity and start treatment appropriately according to the general report. And I'll just probably broadcast that in a little while. So this is it. And this will be probably my last slide, I know. My time is fast spent, but yes, so when we decide to start treatment for asthma, overall, you'll hear doctors talk about controller and reliever therapy. Now, remember that the hallmark of asthma is chronic inflammation, and we need to control the chronic inflammation. That's the medicine we will refer to as controller. And quite typically, it will include an inhaled corticosteroid for most patients. And for others, even when the symptoms are quite stable, once in a while, you will tend to get an increase in symptoms, or what some people will call an attack. And when that increase in symptoms comes about, then we will start you on treatment we call reliever therapy. Now, the reliever therapy is not to be maintained at all times. It only comes in when you have symptoms. You usually don't touch this reliever therapy unless the symptoms are there. So most people actually are quite well controlled, and they will continue using their maintenance dose of the inhaled steroid without needing the reliever therapy. Usually when someone relies on the reliever therapy, it might actually indicate a number of things, including among them poor inhaler technique, inappropriate dosing of the controller medicine, but also sometimes the patients will run out of the medicines without actually knowing that the medicines have run out. And when that happens, we will really need to review them and try to find out why the patient continues to have symptoms despite being on adequate therapy for the asthma. So this is really what the general treatment graph will look like. So the patient typically will be started on treatment depending on the symptom burden they have and the frequency of the symptoms. And then after that, we'll have to review them routinely to make sure that number one, they're responding to the treatment. Number two, they're not experiencing any side effects. Number three, that they know how to use the medicines, they know how to refill the medicines, and they know what to do when they start to get, those symptoms. But also we teach them on how to prevent those symptoms from coming. For some people actually who have significant response to a number of triggers, trigger avoidance will be among the pieces of advice we'll be giving them on a clinic visit. So I will probably end here in the interest of time, and we will wait to see if some questions emerge at the end of this.
Great.
Thank you very much.
Great. Thank you, Dr. Wincy, for really setting the stage for our webinar this afternoon. And as you presented, I thought it is just a natural step for Violet to come and tell us her lived experience of having asthma disease. So,
all right. Thank you so much, moderator. 10
minutes if you can.
Yes, I should. Am I able to share my slides? I did a few slides.
Okay, we shall get them projected.
I have them with me. Can I share?
Yes, you can share.
All right, go ahead and share.
Thank you. Oh.
And members online, if you have questions, please go ahead and throw them via the chat. We are going to pick them from there and have them reviewed by our panelists.
So, Mr. Moderator, may I proceed now?
Yes, you're invited to proceed.
Okay. Thank you so much again for giving me an opportunity to speak to, I believe, a team of experts and the team that have really helped me to be where I am. I can first tell you that given the weather these days, I should be in a sweater with a scarf around my neck, sneezing and coughing, but I'm not doing any of those things. Thanks to the management, the team at the Lungs Institute has been doing. So
that's a good report, yeah.
My structure of the presentation is really the introduction which you did, but just a bit of clarification. I lead an organization in Uganda. It's a regional organization. We work in Kenya, Tanzania, and here. And we are researchers. We do both qualitative research. We have a high frequency mobile phone survey with about a pan of 3,000 respondents, but also I do lead other qualitative studies. Away from that, I'm also a Rotarian, but also to mention that I prefer to be called a conservation biologist. I did share a bit of my profile. So in terms of what I'm speaking about, I think I have signed a social contract with my cough, and I'll use the word cough for the reason that my earliest memories go back to the point when I was really small. Something is not right with my PPT. Okay. What I recall very early as about 3 or 5 years, my mother would press my nose when she has beaten a raw egg with lemon and some bitter herbs, whose name I don't know, and then force it down my throat because the cough wasn't clearing. When I started preschool, nursery, all these, I think these are antibiotics, came into play, one after the other. Of course, as I grew older through university, I ended up in the Heart Institute, I ended up in a number of places, and all these things were being done. But at that time, I think the people who were managing me started realizing these are symptoms of asthma. And then I went on some of these drugs. Of course, much later in life, I have had very good examinations and assessments where this treatment, and I've been on proper treatment and management. Just also to mention that the most recent which turned around my life was honestly a flu shot, and I'll talk more about that. But I'm also a lucky parent who happens to have given birth to asthmatic children. And it's important, I was listening to Dr. Wince speak, and I noticed some of the things he spoke about in terms of the manifestations, how asthma presents. I think I have seen all of them in my house. But in terms of the triggers, we are all triggered by different things in my house. my firstborn, cold weather, dust, flu, but also when he's on the court. I've been called a few times when he has collapsed on the court, basketball court. My secondborn, in his early days, fish. A few spoons of fish soup or fish food were enough to turn his eyes red. They were enough to have his nose running, and he would be running for a nebulizer in a hospital. And sometimes it could go bad and you even end up on oxygen. Now, for my daughter, it has only been cough, but most of the time, the last time we did assessments, he tested positive, but she's asymptomatic. And for my case, eggs, fish are not even in my diet. Flu, cough is a big thing. So you see there are certain commonalities in terms of what are triggers. And one of the things that is common, flu is common across the board for us. In terms of how we've managed the asthma at home, because everyone in my unit is asthmatic, so we are each other's keeper. Warm clothing, we take hot fluids, we consume animal proteins in moderation, but also we try to follow the routine meds that we've been given. Of course, Montelukast is fairly a recent drug. Symbicort is equally fairly a recent thing to us at least. And occasionally we are put on those things and we manage them. But we try to avoid dust. But of course the question then becomes, our country is very dusty. All the roads are earth roads. So how do you deal with dust? Just to say that we have actually signed a very nice social contract with asthma. We have built very healthy relationships with our doctors and the medical professionals that support us. And I feel we are doing great where we are right now. But for me, what have been some of the key things that have stood out for me as an individual? Asthma can be a very challenging disease in the sense that many times people present different things and it will show in different ways. Like, for example, my firstborn, when he has his attack, the only way we know that he's in an attack, we will basically see him turning purple, the extremities, his fingers, his palm, the end of his skin, the end of the feet, he becomes purple. And then gradually you see him weakening. He could even collapse when you're watching him. And then you know that's a problem. The second one, the boy, the secondborn, the eyes redden, he will be having a lot of flu, he will start coughing, and sometimes he presents eczema like for a week. Then you know you're going to have a big eczema on the under of his arm. Now for the girl, it's normally the flu, and for my case, it starts off as a cough. And normally those coughs will come like at midnight, 3 a.m. or very early in the morning. And you can cough from midnight up to morning. But also the other thing that I have noticed is that when these episodes start, they can last a few, maybe an hour, but also I can have these episodes lasting months on end. The most recent one was the one which started in March last year and did not calm down until it was like end of July. So there's that. But what I've learned also is that this means that not everybody presents a who is. Different people, different manifestations. And I think because of that, there are many cases of people that might go undiagnosed, especially in the countryside. But also to mention that when you're up country, it can be difficult to find the right meds if you haven't traveled with your own drugs. And also to mention that normally when these episodes start, like for my case, they take so long to return to normal. And of course, one is asking yourself, what are we really dealing with? And there is quite a bit of stigma. I've experienced that a few times, like where I'm currently working. When I first had an episode at work, people thought I had TB. And to convince people otherwise was really difficult, even when I have all the paperwork and sometimes you really don't have to explain yourself. But the most important thing that I thought I could share with you guys, maybe you already know, it is the fact that last year when I got a flu shot, since then it's been 10 months. I have not had an asthmatic episode again. People around me have had flu. People around me, even people have had colds and things. It's cold now, people are wearing scarves and sweaters. I'm walking just in a small blouse and I'm okay. And I'm not coughing and I'm not wheezing and I don't have the chest tightness at night, even when it has been extremely cold. I believe that if maybe this was something that is accessible to many other people, we could improve the quality of lives of the many people out there that are having to deal with the symptoms and the uncomfortable conditions of asthma. Thank you. Back to you, moderator.
Yes, I was asking IT to help me here. Thank you so much for sharing your lived experience. We are going to explore that further during the Q&A. However, thank you for sharing that aspect. And I'm very happy to learn that you benefited from the flu shots as advised by Dr. Wincy, and you have enjoyed a fairly symptom-free life for over 10 months. That's what I seem to have picked from your presentation. Thank you once again. And at this juncture, I would like to invite Professor Lynn to also speak to us as part of the stage setting. This one is now the data. What does the data show about air pollution in Uganda? And what can we pick from this data? Thank you.
Okay, thank you very much. And like the rest have done, I tried to be short. Fortunately, some of the important information has been given out by my colleagues. So I'll be a bit short, but I'm representing this because of my association with the Eastern Africa GeoHealth Hub, which is a consortium of universities across Africa and the US, and these are listed here, and I acknowledge them. So indoor and outdoor air pollution remains a very, very big challenge, both for the urban and for the rural populations, not only here, but some other middle-income countries. And it is a very major environmental risk to health because it's associated with disability and premature death. And the case in point is now asthma, and we've just had somebody who has had a lived experience with it and her family. But also there are other problems that air pollution is associated with, other respiratory diseases, chronic heart diseases, stroke, and other lung infections, TB, including actually low birth weight for the unborn children. So it's a big issue that we need to tackle as a country. And also, according to some information that we have, almost everyone, 94% of the population depends on biomass for both lighting and cooking. And that's a big challenge. People tend to only think about traffic-related pollution, but actually we are largely all exposed, especially some of us who grew and lived in up country, and for me, in a very cold country called Kigezi. So we are exposed because we need to look for for warmth, from the kitchen. So air pollution is a very big challenge, and also it's a problem of socioeconomic development. So it's attributed to mortality and morbidity, including asthma, and also thus it's needed to generate a lot of information that is helpful. In the urban areas, you can see I've put some few pictures to demonstrate what is happening that you see when you are driving in the streets of Kampala and the suburbs. We see a lot of burning of rubbish and other waste, which is a lot of mixtures of chemicals the middle picture denotes the cooking style, especially in the peri-urban and urban areas. But in the rural areas, it's well-built kitchens and without ventilation. But also we have cars that are either unserviced or they are of age that should not be on the road. And thus the need for the Minister of Water and Transport, including Uganda Revenue Authority. So I am showing you a slide that shows what we at the School of Public Health have. We've been fortunate to have done research with a number of experts for the last 7 years, not 20 years, for the last 7 years. And this equipment is called BAM 1022, and it's located on the rooftop of the School of Public Health. And with the collaborators from University of Southern California, from Columbia University and University of Rwanda, but also from the EPA, Environmental Protection Agency of the US, when we were setting it up at the rooftop. It monitors the quality of air that we have. So my colleague Wens has already talked a bit about asthma and air pollution, which is good because he went into my lane. Thank you. So air pollution makes asthma symptoms worse, and it triggers off attacks. And the people with asthma are at greater risk of breathing in these very small particles. Small particles, we call them particulate matter, small, very small, 2.5 micrograms. And these make the asthma worse because they cause actually short and long-term exposure, and they go nicely into through the airway into the lungs and into the bloodstream, causing much more trouble. And a number of studies have been done and have shown that effect, including this one done in Uganda, I think, where I think one of our colleagues, Professor Bruce, was involved, which gives that 11% prevalence. This is data from part of our data from indoor households in Kampala. And I just wanted to highlight that lack of employment and socioeconomic status actually is also a risk factor. So there's a lot of unemployment, but also places where people cook matters very much. We have households that cook in the sitting room. We have households which have a kitchen with a mat as the door in between, as the barrier in between, and the fumes find their way not only in the sitting room but also in the bedrooms, and they are encapped within where we sleep, and you can see those proportions. But also the type of fuels that we use is largely in these urban and peri-urban areas is actually a big proportion, up to almost 90% use charcoal. A few people use, I think, electricity for boiling water to drink. And yeah, largely, and few have LPGs. So I didn't manage to analyze data for specifically asthma, but I wanted to show you a picture of what is happening with TB, for example, in relationship with the air quality, air pollution. So this is data from the BAM. And to the y-axis, you have the PM2.5. And then from the x-axis, you have the number of years that have been monitoring. So you can see the trend of air pollution, which is by PM2.5 micrograms per cubic meter, is following the same trend for this lung disease. If you continue, the same for pneumonia, the pattern is the same, and I'm certain that it is the same for also for asthma. This graph also shows actually shows that we actually have, during the months of when it's very dusty, as one of the persons presented said, which is January, February, and March, we have very high air pollution, completely unacceptable. 80 micrograms per cubic meter, meaning that the expected mean would be actually 5 by WHO standards. So the clinicians, you should fold your sleeves for this problem. And this is actually data of indoor air pollution in households of relative low income in Kampala. And you can see the average PM2.5 concentration from these people that we measured is actually 5 times higher than the guidelines given by air quality guidelines of 2021 that were revised. So it's no wonder that we have a number of problems that are happening. And I thought I should just show you a little bit of what was happening during the COVID time. And we analyzed data across 2018, 19, and 20 by the different months, and only zoomed up to June. And you can see why the trend is the same. The green line graph shows how nice it was to breathe during COVID lockdown. In fact, there you will safely actually jog along the freeway, highway. But now I wouldn't advise you because you'd be taking in very dirty air. Winceslaus already told us that we breathe up to 11,000 liters, cubic liters of air in our lungs. This graph, these pictures were taken during the COVID lockdown, and you can see, you can guess where this is, including Kalere, but it all shows blue skies, even in these suburbs, a few cars on the road and none for some of the streets. This is data from this equipment, and it's the BAM 1022, and it is showing the different air quality interim measures. So the interim one, which would be 35, about 35 here, is where we are nearest, which is the interim one. But the average for Uganda, I mean for Kampala, was actually it's about 39-40. So we are nowhere near the guidelines, even if we took the interim 1, 2, 3, and 4, plus the standard expected, which would be the 5 micrograms per cubic meter. We also have done health impact assessment, and we basically find that we could attribute about 17% of death due to air pollution if we take the standard of 5 micrograms per cubic meter for the different years. So given the 10 minutes you gave me, let me conclude and say that it is safe to say that socioeconomic determinants of health, such as these environmental exposures like air pollution, are very important, and the earlier we deal with them, the better. And therefore, the stakeholders need to work hard to deal with, especially Kampala State Council. I'm seeing the old mode. Kampala State Authority need to do much about the rubbish burning and collection, as well as strengthening regulation, so that we follow our regulation. In fact, when you are in traffic and the motorcycles start off when the traffic has released you almost don't know how this policeman will survive the next night. I thank you.
Thank you, Prof. And I think you made very good conclusions from the data and research that you have conducted, which is a good setting for our commission, I guess. So I don't know, you can speak to us. Dr. Nsungwa is going to speak to us. She doesn't have a presentation, but she'll summarize for us some of the policy issues we have picked up from the ministry.
Thank you very much, listeners, and thank you very much, my co-panelists. I think you have made my job very easy. But before I start talking about the policy landscape concerning air pollution and lung disease, and in particular asthma, I want also to reiterate, I think my colleague Wincy said it's a complex, it's a chronic disease. I want to say it's a complex disease. It's a complex disease because it has multiple layers of influence. We've learned about the pollution, but also the cultural things, the parenting, the genetics from my colleague. You've seen how all her siblings have a problem, but also it has multiple risk factors. And I think Dr. Lynn has ably presented some of the risk factors. But also just to mention the issue of crowding, in the houses, and also the issues to do with other stress factors in the family, which also worsen asthma cases. But we also have the problem of cumulative risk. You start off with simple asthma, your lungs continues to be damaged, and you end up with chronic disease. So it's really a very big problem. And in Uganda, like he has rightly said, our information does show that the commonest cause of pollution is traffic emission. And it's very sad because I think his data he has shown, which he has been showing, actually shows that probably this is actually a big crisis. I don't think it's even a problem for now. I think it's a crisis based on that data. But also the second commonest cause of air pollution is indoor pollution. And here I want to emphasize not only cooking, but burning waste. Many people are burning waste in schools, there are no incinerators, and that has become a very big problem. We have several policies and approaches to this very complex problem, I've said. And I want to start by talking about some of the issues we have, and one of our main focus, we do this through our national communicable disease program, but also through the school health program. We have been able to institute several programs to improve both early identification and appropriate care, including emphasizing health assessments in schools. Asthma management plans have been developed and are being disseminated. We're also educating students and staff and parents, because the problem of asthma basically is not only a breathing problem, but we also see children, because of the problems of breathing, that they end up with sleep disorders. And this immensely affects school attendance and school performance, but also emotional problems and obesity, which are consequences of this problem. We are also working with the neighboring health facilities, the schools, to be able to improve the access to medicine. We have a school surveillance system, and COVID has helped us to strengthen this, where we're now picking information, school health information, through our health facility to be able to account for some of this disease burden and plan for them. We also have, in addition to the school health surveillance, we have surveillance system for flu. And I think that also was very important for us when we began picking up COVID. We have sentinel sites in the country which monitor flu incidents. And then we also have programs in the ministry which are trying to push issues to do with oxygen policy, because we know oxygen is going to be one of the key elements to help these children survive or patients survive. And through this oxygen policy, we've been able to set regulations and guidelines, but also make sure that appropriate equipment and infrastructure is available. We are currently piloting a medicine kit system in the schools, because we know that about 15 million children in this country are in schools. So our main focus concerning asthma is around schools, and we are introducing a medicine kit to the schools, which will be delivered through the health facilities to support on some of these common ailments, including lung problems. The other area we're working on is on ambient oxygen, having oxygen in the homes, but also supporting the ambulance emergency crew system team to be able to manage patients when they have emergencies. We are looking at supporting people to have oxygen in the home in a guided manner, both who have chronic problems, the elderly, but also some children who have severe asthma. So we have several guidelines and systems which have been put in place. However, since I said that this is a broader problem, we are also working with other sectors. NEMA, for example, has developed guidelines for indoor air quality in schools, and these are being implemented and rolled out across the country. We are working with Ministry of Education. They have also included environmental education in their curriculum, including common ailments, and they are setting up systems. We're trying to push and foster for systems for having school nurses in most of these schools. But we also work with several initiatives and partnerships between schools, communities, and other organs. We have, for example, the Clean Air Green School project, which is being led by the Uganda Coalition for Sustainable Development, who are trying to promote clean energy and waste management and environmental education in schools. But also we are working with other international partners and sectors to try and see whether we can actually work on the underlying factors in these places. Clean air in education setting is our main focus because, as I said, most of the children, 15 million people are in schools currently, and that has been our main entry. But we also have some other programs which are trying to promote things to do, like, for example, planting trees, because we also know that trees are very important, and the campaigns in schools for planting trees are one of the examples, but also the use of clean energy, promoting solar, use of solar and biogas, and also implementing the green transport system, which is basically promoting walking, cycling, which I think has already almost completely disappeared in our urban areas, but also use of public transport. So we are working with the major cities, including Kampala City Council and the planners, to see whether this can actually be planned for. It's a big challenge. Not only do we have funding problems because of this, but we also have resistance, change. So we are going to have to do with to work with a lot of people to support these systems. We have some few data which has been coming in from the schools, and data shows that for every 30 children, 1 or 3 children have asthma-related symptoms, either mild ones or severe ones. So this is a growing problem, and I think we need really to respond. So I want to thank all our partners and people who have been supporting us and working with us, but also to reiterate a commitment for government to support and address this issue. Thank you very much. I'll stop there for now.
Thank you, Commissioner, and thank you once again to our panelists. I think this has been very, very insightful, educative. I have been tracking some of the comments via the chat, and members online are really excited about the webinar. We've come to the end of our first segment of the session. I now want to moderate the second session, which is essentially Q&A. This is a combination of earlier questions and those that have come through from the chat. Prof, I'll start with you. And the question I want to start with is really, can you give a statement about the state of the quality of our air in Uganda? Are we in a hot zone? You know, should alarm bells be ringing?
Thank you very much for that important question. And as I have already showed you, we are doing very, very badly because we are completely out of range. Just to give you a comparison, for Nairobi City, for example, they have managed to control their air quality, and their measurement is actually 20 micrograms per cubic meter. And for us here in Kampala, we are about 40 micrograms. Yeah, for ambient air pollution. If we talk of the indoor air pollution, I've already given you some hints. We are 5 times as high. And we have now several monitoring devices. We have one at the School of Public Health. We have another one at the American Embassy, which actually reads much, much higher, I think because of that traffic and zone from Zambia and its location. And I think the Air Corps group at Makere has another 2 equipment. I think maybe they are maybe for 5 months or so. So we are not doing well, and I call for action by our policymakers to ensure that we have clean air, which would help us save money in a way, because we would save money by reducing the morbidity and mortality as such. Thank you.
Thank you, Prof. And I noticed in your presentation, you had the seasonality to asthma presentation and exacerbations, I guess. You said something about that.
I can also say that while I did not present actually asthma data, I presented TB data, I presented, I think, pneumonia data, but the trend is not very, the pattern is not different, meaning that the higher the air pollution, the higher the possibility for hospitalization and even the death. That's what our data, and our data is from 5 large hospitals in Kampala. So it is much
robust. Okay. So colleagues online, I think those are very insightful comments from the data. What does the data show? Linda, I want to also pick up some more conversation with you concerning your lived experience of having asthma. I noted that you testify that the flu shot that you got been a big reliever to you. As providers, we are curious why patients do not take up these flu shots. Is it because of limited access? During COVID, there was a lot of, they used to call them anti-vax campaigners. Don't people believe in these products? What are your thoughts about the vaccine uptake, given the positive experience that you've had?
Well, that's a very interesting question, but also I think a difficult one, because from my perspective is there is an element about how informed we are. How informed are we as people? Of course, personally, I know I had been asking for that vaccine because I noticed every time I got a flu, I would spiral. But for some reason, the many doctors that managed me, none of them seemed to look at it as a possibility until very recently. So I think it's probably 2 ways. One is that sometimes the practitioners, you guys who are managing us, are thinking there are other probably lines of management we can do to handle this. I do not know the side effects though, but I would think on our part as patients, it's really very few people know about it. Because when I shared with my friends and I'm like, guys, nange neti akati, I've not had flu, I've not had this. They were like, how come you haven't done this for all these years? I was like, it's just the time. But also the other one, there is a religious angle to some of these things. You know, Uganda is a highly religious country. And people, if some pastor or somebody tells them don't do this, the suspicion things we have, people will walk that path. But I think if we informed people enough, I think everybody wants to live a good quality life. And they would willingly take it if it's going to ease the discomfort.
Okay. I wonder, Wince, is this part of our clinical guidelines, the vaccine treatments? Because Alinda says she's not received any information about this before.
Yeah, so this is part of our guidance. So for most patients who have chronic respiratory disease, you ought to go through some of the things that will benefit. Now, there is no one size fits all for asthma management. You really have to look at the patient before you and risk profile them. There are some patients, for example, who don't really get any issues when they get flu, but there are some actually who are really greatly troubled when every time they get flu. And for those, usually there should be a plan to discuss with the patient. And this is usually a discussion because the patient has to appreciate the importance of getting this shot and also need to be committed that this is going to be an annual shot. So this is going to be a shot that you're going to take every year to protect them against these rampant viral illnesses that we usually have in Uganda. So yes, for most patients, and this extends to a number of chronic lung diseases, interstitial lung disease, post-TB lung disease, COPD, and a number of others. Even those actually that have post-infectious complications, you want to really introduce them, not just up to the flu shot, but also to the pneumococcal vaccines as well, because we know that actually they really do help to prevent those other infections, or what we call infective exacerbations, yes, for some of these patients.
Thank you. Okay. Linda, I'll come back to you, but maybe I bring in my commissioner at this point, talking about access to some of these health products. I don't know what initiatives the ministry has undertaken to really make sure. Yeah.
So our healthcare system has been evolving. For those of you who have been in clinical care for a long time, I think in the old days, most of our commodities and medication, for example, were just on ephedrine and then salbutamol. But recently we have also updated our commodities, working with the clinicians, and the essential medicine list was just reviewed last year. So we have some of these commodities. We run a system where we have a push and a pull system for the districts. So you find that where we have the biggest burden, most of these hospitals do a pull system. So they have money and they order these drugs based on their requirements. Of course, sometimes there are issues of funding, but you find that some of the big hospitals now with increased funding, something is happening now. We have also reviewed our structure and we are going to have more experts in these hospitals, including having a doctor to be able to manage some of these ailments. So hopefully that will also be very, very good. For the younger children, of course, like my colleague has said, most of these children, most of the attacks are preempted by common infections, and vaccination is a very important thing, not only for flu, but also for Haemophilus influenza, for pneumococcal. These vaccines also have been able to impact on the frequency of some of these lung diseases. I want to talk about self-care. Self-care is a new mode of approach for care we're trying to push for, and we have run several interventions to support people, including treating diabetes, injectable family planning. So we are kind of expanding the scope because we know there are many people who are left behind in some of these communities. We also have a mapping and we know where some of these problems actually are clustered. So we also have a very targeted approach to this. But I must say, like I said, the issue of pollution is a big problem. And I don't know, I think we need to do more advocacy, but I think we need to discuss, as you say, the root causes. I think it's one thing to worry people, but it's another thing we have the evidence now. But I think how do we focus on the root causes? And there are so many duty bearers here. We need to continue. In the UDHS, we're going to have results in a couple of months, and we have included asthma as one of the areas. So hopefully we'll also be able to get some more population-based data to support some of these areas. So we are moving on, we are evolving in. We have more urban areas coming up. The problem is going to increase before it can reduce. So we really need to work together and push this area.
Thank you. Maybe I just extend this conversation a little more. Did you say that asthma is one of those health conditions that you're going to incorporate in the community health systems?
Yeah, for self-care. And it actually goes beyond community because now this is about individuals being able to do it for themselves. And we're training community health care workers to support those people who are going to be doing self-care. So we have a program, we have a policy, and gradually we are rolling it out and we're expanding. We began with the simple things, but now we're expanding it gradually based on the burden of disease.
Thank you. I just think MLI is, I don't know whether we are positioned to support this shift because I think a lot of capacity will need to be developed for these community actors. Prof, I want to come back to you again. You mentioned issues of indoor air pollution versus outdoor air pollution. And for a layman like me, I was wondering where is the biggest problem? Which of the two is the worst evil? Where do we start? Which one do we grapple with first?
I don't know if you're a layman, but but I think we should take it together. Okay. Because we spend in Africa and Uganda, we spend 12 hours outside, therefore taking in ambient air, and another 12 hours, indoor because of our tropical nature. And as you have seen, indoor air pollution is a big problem, and majority of the people are poor, and therefore the housing structures and the use of energy in the houses is a challenge. So I think while at a macro level, at a bigger level, we need to be taking care of these policies, all the vehicles, traffic, biomass collection of these refuse and burning. That's at a higher level, and also industries, their emissions at night. In fact, we at one time wondered because there was a lot of air pollution at night, and we wondered why, but only to discover that some factories, I think, go beyond the guidelines and emit more at night. So I think at the macro level, we need to do that, monitoring at the NEMA and yeah, we need to do more, but also at the personal level, we need to incite the communities for the air use, for the fuels they use at home need to be controlled in a way, but also we need to ensure that the biomass will run away from charcoal. Charcoal is a very expensive thing if you realize. True. But if we went for LPGs, I think we'll do much better with clean air, rather clean fuels rather than charcoal. So we need to take it together.
Thank you. What I take home as a layman is that the two need to be handled together.
Correct.
And as you mentioned earlier, sometimes we think of outdoor air pollution, mainly, but we cannot ignore the issue of indoor air pollution. Thank you so much for that response. Linda, as you did your presentation, I missed your aspects concerning your work life besides the stigma. Oh, now that Wincy has controlled the asthma, you have no issues. But perhaps your previous lived experience with asthma and work life. Do you have anything to share on that regard?
Of course I do. For the greater part of my work, I think I've been privileged to work with a number of organizations, but all along that path, my personal life and work life are together. And for me, one of the things has been, I have always been that one worker, when she gets flu, she'll be out of office for even 5 days because she's struggling with her chest. But also, asthma helped me deliver a child prematurely. Because I went in an attack and the baby had to come out a blue baby, but of course now a big girl. So I think it does affect the quality of your output in terms of how much you can do. And sometimes when we are on the medication, especially PRED, and sometime back I used to do, I think, when they give you some of those medications, there is a way they affect your physical well-being. And then that is hurting how much you can do. But also there are moments when you are not able to work just because either the weather is too cold or the place is so dusty you don't want to expose yourself. There are all those kind of things, but also the question of how other people feel about you. I'll just share this example. I reported in an organization for a meeting and I was on a very cold flight. So when I walked into this meeting room, there were a number of white guys in there. And immediately I started coughing. One of them walked up to me and she went like, "That must be a very bad infection. You need to see a doctor." So there is that. And so every time people are looking at you suspiciously. But of course, when you get it, and I've also received the same experience in a medical facility. Of course, I won't mention the facility, but a big one. And I walked in there, I'm coughing, and I was immediately isolated, immediately. And then when they ran the X-ray, because I was told to do an X-ray immediately, the doctor just told me he was sorry. So, I mean, I don't know whether that kind of paints a picture, but that's what I could share.
Okay, yeah, it does certainly, and not a good picture though. And I really hope that we shall address this problem because it negatively affects aspects of your work life, social life, and even the way people look at you, you know. So thanks for sharing that, and we take note. Wincy, you had a couple of questions, although these were mainly clinical. For a start, I would like to get your insight. You know, MLI, of course, is a specialist land facility center, but few patients would get to the Lung Institute to receive your specialist care. I don't know, does MLI have any plans of capacity development beyond the Mulago Hill?
Yeah, well, thank you so much, Mr. Chair. Indeed, we are quite few to handle the entire 41 million, population as Uganda. But we really have embarked on a capacity building drive, and we have done quite a number of CMEs around Kampala, and with the help of the Ministry of Health, who really has been a very strong partner, we are taking some of these CMEs even up country. And one of the other things, of course, is that as the institutes, there have been some courses that we have developed that have also recruited a number of healthcare workers in primary care. And some of these, I think some people might have heard about them. They are called the iBreath courses. And these really help to build capacity, to somehow simplify specialist care at the primary health care level. And again, this is a very big area of fund that we are tackling. And but we are very thankful, of course, to all the important actors and partners that have helped. So I don't think we will be able to do it alone. But I think it's very important that we have very strong support from the Ministry of Health, and that has really also been very supportive of this. And I think you probably also have known that even the medicines have changed. Now the Ministry of Health is buying inhalers now. And part of that, of course, will also be part of the rollout will also include capacity building, where we teach everyone at primary care how to use the inhalers, which patients, how to prescribe them, and things like that. Yeah.
And I noted as you did your presentation that actually making a diagnosis of asthma is not a straightforward. Yes. So I think a lot of capacity building needs to be made, even from the point of diagnosis. There's a quick question to you here, Wince, before I summarize the rest. Can you comment on whether 7-year-olds, I think with asthma, could participate in athletics? I don't know. It is from the chat.
Yeah, thank you so much. Now, you might have, probably you might recall that at the beginning of this presentation, I really highlighted chronic inflammation as a hallmark of asthma, and that how almost every treatment that we bring on board is aimed at controlling and reducing chronic airway inflammation. Now, exercise is a very important intervention in this regard. So we actually want every asthmatic to actually participate in exercise. And if there is anything that will limit them, from participating in exercises, then we usually will go a long way in controlling their airway inflammation. We have seen very many people in the athletics world. Some of them are runners, others are really, players of football and rugby. And, when they complain that they can only do first half of 45 minutes, and after management, they can do the entire game and even still be fit at the end of the game. That's actually the kind of stories we're looking at. So exercise actually reduces airway inflammation. And that's actually why we want every asthmatic to really be involved in this, not just really reducing airway inflammation, but also improving lung capacity and the lung reserve. So you actually see that asthmatics who are physically fit tend to feel these exacerbations less often than those actually who are not physically fit. So we want actually, every asthmatic to be as physically active as possible. And when you realize that even little activity is triggering their symptoms, then it actually means that we have probably neglected the animal in the room, which is really controlling their overall asthma symptoms. Because as we know, almost every asthmatic will have some form of exercise-induced bronchospasm. So, and once you control their baseline symptoms, then they'll also participate very easily in physical activity and exercises. Yeah, so we really want every asthmatic to participate in exercise. Yeah.
Okay, athletic activity. This is a very important message, Wince. I don't know, Linda, whether it speaks to some of the myths I've personally picked in the community that asthmatics do not engage in physical activity. So I think, Wince, this is a message we love to push out there.
Yeah.
because of the benefits you cited. There are a couple of questions from the chat which were clinical, and I want to say that we should possibly handle these via our usual Day of Lung Science events. There is a topic, there's a question around asthma in pregnancy. There's a question on when to stop some of the medications, the controller medications in asthma, issues of use of magnesium sulfate and the Montelukast treatments. So colleagues online, we have picked up these questions, and we promise you, we are going to really arrange a dedicated Day of Lung Science speaking to these questions. In the interest of time, we cannot handle them fully here, but our head of department has taken this up. I would like to quickly bring this towards the closure by inviting you to speak to some of the Commissioner. Do you want to speak about any policy research issues or gaps you may want to?
So thank you very much. And I think I like the last comment, because we know that most schools now have got rid of green spaces, and that's a big problem. But also we know children with asthma have so much anxiety, they have behavioral problem. So the more you keep them without activity, the worse they become. But back to the issues of policy, I want to talk about what we are doing in general. Like I said, this is a big problem, but it's also a broad problem. Currently, most of our focus in the government is to look at human capital development. Gone are the days when we mostly were interested in making people survive, but we're looking at the well-being and the long-term benefits. And some of the areas we're trying to capture under these new policies, the National Development Plan, are mostly based on working out the benefits. So some of these problems like asthma, with or without air pollution, we need to make sure that we make a clear investment case. We need to quantify the gains, because we are all crowded on the same budget. We need to work out the gain, the benefits, and align them with our vision and our thinking in terms of looking at long-term gains. Interestingly, last week we started having a discussion with Minister of Finance on safety. Who's responsible for safety? Who's responsible for food safety? People had the way people eat in town all over the place, the garbage, and now, of course, the air pollution. And I was very interested because the same person who was discussing is the one who's driving the human capital development agenda, is the deputy chair for our cluster. And I think the question was, how do we make sure that we can actually present this into monetary gains so that we are able to join the policy dialogue table where we are discussing handling hanging fruits, despite the fact that we have data on the side of the problem. They are competing activities, but we need to center this whole problem of asthma and air pollution. Lucky enough, we also have political support. You've seen His Excellency writing about garbage and what we can do. So I think the momentum is on. So we need to have more research, try to understand actually how much we can gain from this, but also continue mapping the problem in the country, but also making sure that all the other sectors are working together. What would it take if we work together? Of course, there'll be more efficiency, but who is responsible? So we need more evidence and more information in that area. The other thing I wanted to talk about is also about medication. More and more medication is coming, but we also have adverse effects, misuse, irrational use of medication. There are a lot of pharmacies. Every 5 meters, you find a pharmacy. So again, we need to look at the issue of regulation to be able to protect our people. In addition to looking at their safety, I think the issue of regulation. But I also want to encourage people that we have a big problem with pollution, but also there are countries where they have been able to deal with this problem. And I like that the fact that the professor did not go to Europe or America, he just talked about Nairobi. So I think we also need to benchmark and maybe work as a region, maybe, and handle this problem as a regional problem and see how we can also improve our country and safeguard our people, given that actually this is a growing problem. We have new cities, but also make sure that we inculcate the culture of learning, community awareness, training people to understand these diseases, because we lose so many children in the early ages because the parents don't know. They are shopping around the whole place, including traditional place. I think for me, prevention, having a public health approach, increasing awareness and investing in information sharing, but also guiding people from other sectors will be the most important thing. A multi-sector approach, which is focusing on prevention, but also increasing awareness would be our best buy.
Thank you, Commissioner. MLI, I think, should be able to support this investment case. Of course, the ministry will take leadership of the multi-sectoral accountability framework, multi-sectoral approach. I talked about accountability framework because we use that a lot in TV. But really, Commissioner, like you mentioned, this sort of problem needs to have a multi-sectoral approach in order to really handle. And of course, explain to the people who handle the finances what are the economic benefits when asthma is controlled. Linda, being a person who has lived with asthma, I don't know if you have any parting remarks for the audience as we come to the closure of our webinar.
Thank you so much, Moderator. Of course, they are really, my biggest takeaway from the discussion is the intervention of monitoring air quality in schools. Like I mentioned, I'm a parent, and so I know the run-ins I have had, picking an ambulance here, going to pick a child from this school and that. I wish we could really do something about that. Many of the boarding schools children are sleeping so badly. But I also wish we actually had gazetted clinics like in the countryside, where one can go and access these, we call them commodities or supplies. There are areas where you can hardly get these supplies when you need them. But also equally to say thank you so much for giving me this opportunity. I hope the cost of the flu shot and maybe others could be subsidized. I want to believe it would not be affordable for ordinary people who are not having a monthly income and stuff like that. If we could look at ways to reduce those costs, I think life would be better for all of us. Thank you.
Thank you. I actually missed the price. The commissioner is here. It would be nice for her to hear how much it costs you to get the shots.
Yes, it cost me 90,000 Uganda shillings.
Yes. Wow. So she's taken note, and I think she will advocate for your plea to have this reduced.
Thank you.
Prof, do you want to give us any parting?
Okay, so ladies and gentlemen, thank you for attending this important meeting. I have 3 things I want to leave us with. The first is that motor vehicle inspection is a very good panel for air pollution. Some people don't service their vehicles, and so that's one thing. The other is mass transport. So for policymakers, we need to have Kampala, at least I've seen some buses going to Entebbe and Ntinda. I wish we had regionalized transport, mass transportation. That would end out these taxis that we crowd the town and not service. The other is about enforcement. I wish enforcement was done very vigorously so that we have inspections of vehicles done, and they are inspecting for a driving permit when you have a car made in 3 years old, but they leave a charcoal carrying vehicle which is very old without any credible way to move on our roads. I wish there was a way to do that. And I end with a small story of 1 minute about a parent who contacted me because when he took a child to senior 1 on a school which is on Ginger Road, a few meters off the road, a very good school. And from day 1, the child was coughing in and out and was always in hospital. I think she had asthma, exacerbated. So they asked me, what can we do with this child? What should we try? They were really in big trouble. So I proposed to the parents that maybe you should get this child into a school relatively rural, cleaner, green school. And they transferred this child to that school, to another school. And since then, the child has not had any problem. So
Thank you, Prof. That is a very touching story. We really need to breathe in clean air. Otherwise, the poisons really will cut our lives short. Wincy, can I come to you to give us some parting remarks?
Yeah, sure. Thank you so much. I'll probably use this few minutes to, as my parting shot to probably pass some, probably maybe important information of all the questions that came. There's a question on pregnancy and asthma medicines. I'm only picking this up because it might actually save someone out there. That actually, when it comes to asthma in pregnancy, we really encourage adequate control. Again, evidence has shown that all medicines for asthma are safe in pregnancy, apart from the systemic steroids, which are mostly the prednisone and the Dexa. Those really would leave those to the gynecologists to prescribe if there is indication, a gynecological condition. But inhaled steroids are safe in pregnancy. Montelukast is safe in pregnancy, and the combination of inhaled steroids and LABA as well. So those are actually safe. So to improve outcomes for mothers, pregnant mothers with asthma, they should, at the bare minimum, at least be on an inhaled steroid to improve their outcomes. But where need be, if they need the combination of an ICS LABA, they should also be prescribed, those medicines. Otherwise, they really, are at risk of having a very rough pregnancy and perhaps even premature delivery and premature birth as well. So I think that is where the important information probably may not wait for the next day of lung science, because it might actually save a pregnant woman out there or even an unborn child. Yes, thank you so much, Chair.
So I would like to once again thank you, the audience, for listening in to our webinar, but also very importantly and especially thank our panelists. We have the commissioner here, Dr. Nsungwa, Professor Lynn. We have Ivan in the room, Wincy, and Akela. Thank you for making this a possibility. We are really very, very thankful as a Akela University Lung Institute. Before I bring this to an absolute close, I would like to invite Professor Bruce Chirenga to really speak to us as the director of the MLI. But as he comes on, I wish to thank the individuals who raised the questions that came through. We had questions from Rosemary Team, Enoch Sebunya, David Kajimu, Agnes Mary Mugaga, Andrew Mubiru, Brian Nyiro. So we are thankful for these questions, and we are going to pick them up for subsequent CME or dedicated to a day of lung science, which is a monthly event that we hold here at the Lung Institute. So we are grateful to you for these questions, and I'm actually passing them over to Wincy, such that we really address them at another convenient event. Prof, if you are ready, please speak to us, and we bring this to a closure. Over to you.
Thank you, Chair. Good afternoon, everyone. I also want to thank the panelists for the discussion today. And just to also re-emphasize that the theme for this year's World Asthma Day is Care for All. Let's try to see how we can bring as many people as possible to be relieved of the symptoms of asthma. because we know almost 90% of the asthmatics we have in this country are not diagnosed and are not treated properly. Thank you.
Those were very brief remarks, but we are grateful for speaking to us. Members, it is 4:35, and I want to bring this to a close. Once again, thank you for making this a possibility, and let us address and improve prevention and care for asthma in our country. I wish you a nice evening. Over.
Thank you.
Thank you, everyone. This is
Thank
you.
Good.
this is, yeah, if you don't